Hello, my name is Sandra Philip Rafferty. I'm a highly specialist physiotherapist in the outpatient eating disorder service at Royal Cornhill Hospital in Aberdeen, and today I'm going to be talking about exercise. And the question is addressing compulsive or dysfunctional exercise and activity associated with recovery and maintenance of recovery? But first, a little bit more about dysfunctional exercise. This is when exercise significantly interferes with quality of life. Exercise behaviours are rigid and the individual will continue to exercise despite barriers such as injury. Disruption to exercise or being restful can cause distress. It is used as a means of purging or burning calories and is associated with negative body image or body experience. Exercise can be used as the only means to manage emotions or as a permission to eat. There can be withdrawal from family and friends and social isolation. We also must consider unscheduled activity as part of exercise as well. For example, frequent trips to the shops or household tasks. Integrating exercise into the treatment of patients with anorexia nervosa has in the past been considered controversial and sometimes overlooked. We know that if dysfunctional exercise and activity are not addressed, there is greater risk of relapse and chronicity of an eating disorder. Let's look at the evidence. The literature search identified one meta-analysis and 2 RCTs which showed that supervised exercise training programs were safe in that they did not result in additional weight loss. Benefits were found in improvements in strength and cardiovascular endurance, and a reduction in compulsive exercise and other eating disorder psychopathology was reported. There was also improved body image and a reduction in the requirement for secret exercise. One of the RCTs also showed a reduction in anxiety and depression. Both RCTs integrated CBT and psychoeducation, resulting in improved attitudes and beliefs towards exercise. We must consider mitigating risks. Adding exercise to a management program for patients with anorexia nervosa does carry potential risks to their physical health, and psychologically could potentially exacerbate their need to burn calories. Guidance has suggested that exercise should be included with precaution. Patients require assessment and monitoring of their physical and psychological health. There should also be assessment, implementation and supervision of exercise by a suitably qualified clinician, such as a specialist physiotherapist in eating disorders, and there should be a psychoeducational component alongside the exercise to help patients develop a healthy attitude to exercise and recognise when exercise is becoming problematic. So from the evidence we have drawn the following recommendations. Patients should be offered specialist supervised exercise, including a psychoeducational component, as part of a multidisciplinary treatment programme. In addition and alongside exercise, the inclusion and integration of the treatment of dysfunctional exercise and activity should also be considered as well. It is good practice to follow the Safe Exercise at Every Stage guidelines, otherwise known as SEAS. Currently, there are guidelines for adults. There is a separate guidance for athletes, and the guidelines for children and young people are currently being developed. Future research. Future studies should examine how to tailor guidelines to other populations, for example, outpatient care, athletes and adolescents. There should be long-term follow-up studies to look at outcomes for those whom exercise was included as part of eating disorder treatment, and scoping review of service resources and training would be recommended. So that concludes the presentation, and I look forward to answering questions and discussing this further. Thank you very much for listening.